Perceive, process, perform. Do you need inspiration for your practice? Or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Brian Schroder maintains a full-time private practice in comprehensive restorative dentistry with special interest in digital impressioning and interdisciplinary treatment. In this episode of Practice Inspiration, he shares some of his expertise on digital impressioning.
Hello, my name is Brian Schroder, and I would like to express my thanks for the opportunity to present about 15 minutes of information to you regarding a subject that's very near and dear to my heart, which happens to be digital impressioning. And one of the challenges that I would like to issue today is to ask the question, is there a new gold standard in restorative dentistry? Have we found something in restorative dentistry that has the ability to exceed the efficiencies of the current systems that we have in place? So that's what I'd like to discuss with you today. In order to do so, let's take a little brief discussion of impressioning itself. All of us that are restorative dentists know that one of the biggest challenges that we have in our day-to-day practices is accurate impressioning. Impression taking for indirect restorations is a very difficult and technique-sensitive process. But we also know that without a good impression and provisional restoration, nothing's going to fit properly, okay? Nothing will work if we don't get that excellent impression, all right? So if we look at the brief history of impressioning, elastomeric impressioning was introduced with reversible hydrocolloid back in the 1930s. And you can see the progression on the screen that now we're progressed all the way to polyether and vinyl polysiloxane, which happen to be the #1 impression materials that we use in our world of dentistry today, okay? It's important to note that we make those changes, these evolutions occur because we have the ability to increase the efficiency and increase the accuracy of what we're trying to accomplish, okay? We don't make changes in order to stay flat. We don't make changes in order to be less efficient and less accurate. So that's an important point in this discussion today. But just exactly how are we doing with impression material? If you look at us as an industry, if you look at us as a profession, what's going on with us in this stuff called impression material? Well, if you look at the literature, Dr. Samet in 2005 in JPD published an article that basically the gist of the article was they went to 11 different commercial laboratories and they looked at 193 impressions by 43 different dentists. And what they discovered was that greater than 50% of those impressions that were sent to those laboratories were critically defective. In other words, there was a defect significant enough to affect the final restoration, okay? So it's a challenge. The problems that exist with impressioning are very, very large, okay? On this slide, you're going to see some of the ones that I was able to think of. There's many. But some of them happen to be tray selection. Does the tray fit accurately? Is it a good quality tray? Timing of the material mixing to get the impression material placed. Placement around the tooth properly so that you can get an accurate impression. Tray seating, get the tray seated properly, accurately, and then allow the impression material to set undisturbed so that there's no distortion of it. And then all of us have had that experience where we get this impression out and we look at it and it's a good impression, but think about all the post-impression procedures that are necessary for this impression to go through to where we ultimately can arrive at a gypsum dye model that accurately replicates the oral condition. It's a very challenging thing for us to do. Speaking of challenges, my impression, my opinion happens to be that one of the greatest challenges in impressioning is isolation, okay? If we can't see all of the margins of the preparations prior to making an impression, the chances are very, very good that we're not going to be able to get an accurate impression of it. It doesn't really matter what you squirt around it or what you shine on it, it's going to be a problem for us, okay? This is just a photographic demonstration of some of the challenges that we have with impression material. Trying to get the material all the way around the tooth to get it timed properly to be able to make an accurate recording of it. Okay? These are impressions that I made. These are impressions that I took, and I'm proud to show them to you. But the reality is this. Not every time that I made impressions that look like this did I get an outstanding clinical result. And it's because of those post-impression procedures that we talked about before. It's a difficult process, okay? So enter computers. How can computers help us with this problem that we have? Well, when you think about computers in your life and what they do, they increase efficiency and they increase accuracy. Okay? So we said earlier, we don't make changes in our protocol. We don't make changes in our system if we're trying to be anything less than efficient and anything less than accurate. So that's what computers can do for us, okay? We're talking today about dedicated digital impressioning systems. Those systems are listed on the screen. I think those are some of the main ones. Certainly not a complete list. But I'd like to stop at this point in time and say something. I have a firm conviction and belief that success is operator dependent long before it's product dependent, okay? We have fabulous products in the marketplace. Those are exceptional for us to use, but it's up to us as restorative dentists to use those materials properly to affect outstanding results, okay? So these are the list of the systems that are available in the industry that I'm aware of. The scanning technologies as far as data uptake are two. There's video and there's photographic. I'm not aware of any scientific evidence that supports the fact that one is better than the other. I will tell you from personal experience that video data uptake tends to be faster in my hands, and so it's a faster, more efficient process. We're going to talk today about a clinical case to be able to demonstrate digital impressioning in our restorative offices. In this case, we're going to actually do a partial coverage lithium disilicate restoration on tooth number 4. This is the preoperative buccal view. An occlusal view of our preoperative condition. This patient has some recurrent caries, a crack in the mesial marginal ridge, and some biting pressure and cold sensitivity, which are driving us to treatment. So what we're going to initially do is we're going to place a dental dam. I mentioned that isolation is one of the critical problems in impressioning. My experience in my 32 years of restorative dentistry says that the dental dam is the best isolation device that's available, and hopefully I'll be able to demonstrate that to you through this process. The first thing that we're going to do after we place the dam is we're going to remove the old amalgam restoration, identify any recurrent caries and remove it, identify the crack and make sure that the tooth is restorable. And what I want you to see in this photograph is the fact that the interproximal soft tissue has been preserved and protected. When you think about impressioning, one of the biggest challenges that we have is to preserve that tissue and protect it and make sure that we make the impression that we can get a good impression there, okay? The second thing that we're going to do is to build up, a resin buildup. Resin obviously is in need of moisture control. So one of the things that the dam does for us is ideal moisture control for that resin buildup. At this point, we're going to refine the preparation as ideally as we can. And then the first thing the next step is we're going to take and clip the interseptal portion of the dam so that we can expose the entire tooth and enable us to place our first retraction cord. What I want you to note is that the tissue interproximally has not been mutilated by any rotating burr as we've been preparing that tooth because of our isolation techniques, okay? So we're going to place the first retraction cord. It's going to identify the sulcus depth and control sulcular fluid exudate. We can modify the preparation in any way that we need to identify the margin well. And then second thing we're going to do is place a second retraction cord. This retraction cord is a little bit wider, a little bit larger than the first, and its purpose is to laterally deflect the tissue so that regardless of whether we're squirting something around the tooth or shining light on the tooth, we can accurately visualize the margin that we're trying to impress. Next thing we're going to do is take the dam off, and the very last thing that I do before we scan is we're going to assure that we have accurate occlusal reduction, and we can make some modifications to that at this point in time to make sure that it's ideal. And then finally, we're going to place a device called an Optragate, which enables us to see and retract all the lips and cheeks out of the way for direct visualization and access. Okay? What I want you to know is that at this point in time, I've done absolutely nothing different for this procedure to incorporate digital as opposed to conventional impressioning systems, okay? We do everything exactly the same way. There's no change in protocol. There's no change in technique up until this point in time. So let's look at some clinical scanning procedures. We're going to talk about using the true definition scanner. And what you'll see in the base is a CPU. The actual computer is in the base. There's a touchscreen monitor, and you can see a small wand. It's about intraoral camera size that's hanging on the side there. So watch this video as we go through the scanning process. The very first thing that we're going to do is pull the top retraction cord. We're leaving the first retraction cord in place. We're going to evaluate and assess and make sure that we can see all of the margins of our preparation. And then we're going to use a reflective medium, some titanium dioxide, a very, very light application of it. This system still requires reflective medium. Systems in the marketplace today have begun to eliminate that step. I'm sure as this whole technology advances that some of these things that you're seeing today are going to be a little bit different down the road. We're going to introduce the scanner. And as we do, what I want you to note is the size of it. I want you to note that the light begins to reflect off of the surfaces of the teeth. And simply what we're going to do is pass the wand over the surfaces, and the inset that you can see is the screen that I'm actually looking at. As the data is captured into the computer, the screen turns white. And so it's almost as if we're spray painting, if you will, to get all of the data into the computer. The other thing that I want you to note is we're actually scanning a third molar there. When in my restorative world, I don't want to have to pick and choose between impression material and a scanner. I want the scanner to be able to totally and completely replace impression material for me, okay? So as we go through the process, you'll note that we have captured all the information, the interproximal information of the adjacent teeth, and then 100% of the data that we want, as if we were doing a quadrant impression. All we're doing is replacing that quadrant impression with quadrant data from our scan. The full field view that you see on the left-hand side will demonstrate that we're actually looking at the computer screen. There's a little bit of a learning curve that has to be overcome, and that happens to be not looking directly into the patient's mouth, but looking at the computer screen. Now, moving forward, what we've done is scan the opposing. That's in the computer, and I want you to see how we do the jaw relation recording in this quadrant case. On the top right-hand side, you'll note that those two models have been positioned by the computer screen. I'm going to have the patient bite into maximum intercuspal position, and as she does, I'm simply going to scan the buccal surfaces of the teeth. And as the buccal surfaces of the teeth are scanned, you'll capture it into the computer, and the computer has every ability then to relate the upper and lower cast, if you will, upper and lower virtual models into intercuspal position. And at the end of this, on the top right-hand side, right about now, you'll see that the computer has related those two casts, okay? The other thing that's kind of neat about digital is the ability to review the preparations. And so on this video, you're going to see us actually review the preparation scan with up to 50 times magnification. And that 50 times magnification enables us to confirm that we have everything recorded into the computer that we want. So this is a difference in conventional and digital, is that you can review it and know that everything is ideal before you send it off to the laboratory, okay? If there were problems, we could affect a change right now and rescan. If we could we would redo our isolation, refine the prep a little bit. But my experience is that digital makes me a better restorative dentist because I can see my dentistry enlarged on a computer screen, where I was never able to do that with conventional systems in the past. Okay? So we make models. There's subtractive and additive sort of processes in order to fabricate these models. Subtractive would be milled polyurethane. An additive process would be stereolithography. Again, there's no accuracy difference in the literature that's been reported. But this is the SLA model that this system uses as it comes back. You'll notice that this is the cut model. And then the laboratory also is going to get a solid model in order to be able to create the proper interproximal contacts. All right? So the previous model, the cut model, isn't actually cut. It's actually fabricated in different pieces and then assembled into that rudimentary articulation system, which happens to be exceedingly accurate, by the way. So this is our lithium disilicate restoration that the laboratory has fabricated back from the lab. You'll note the marginal integrity and the marginal fit in that photograph. And so what we've done is we've taken the patient now and we've got him back in, and we're going to remove the provisional restoration. What I want you to see is this provisional was fabricated in a way that preserved and protected the interproximal tissue. The contours were great. So the tissue is in the ideal position. The tooth remains in the ideal position. And the laboratory's restoration is fitted onto the tooth. And in this clinical case, I can tell you we did a little bit of adjustment of the distal contact in order to get the thing to seat. And then we did a very slight amount of occlusal reduction on the distal marginal ridge and distal lingual cusp arm in order to get it to seat. But the marginal integrity is exceptional, and I'm overall happy with the quality of the restoration. There's a buccal view of it. Tooth's a little bit dehydrated. This is an immediate post-clinical view, but the marginal integrity is great, and the occlusion was great. And I'm going to say that in my experience in the last 6 years, I've treated over 1,300 patients with this system. And I have done over 2,000 units of restorative dentistry, and I believe in my heart that on its best day, impression material has the ability to equal what computers can do every single day, okay? So to summarize today's process, today's presentation, I think we've just demonstrated that impressioning is a very difficult process. That's the challenge. Impressioning is difficult. That isolation is really the biggest challenge of all of those, okay? We've showed some ways to help with isolation. I would suggest that conventional systems are filled with errors. We've shown some of the errors that conventional systems present us on a day-to-day basis in restorative dentistry. And I would also argue to you that digital systems eliminate, in my experience, up to 80% of the problems associated with conventional impressioning systems are eliminated with digital systems, okay? So I'd like to close with a quote, and that's this: in times of change, it's the learners that inherit the earth, while the learned find themselves beautifully equipped to deal with the world that no longer exists. So that change that we're making on a day-to-day basis to improve our efficiency and accuracy, in my mind, absolutely involves digital impressioning systems. And so to answer my initial question at the beginning of this presentation, do we have a new gold standard in restorative dentistry? I believe in my heart that we do. I believe my clinical experience shows me that we absolutely do. It's been my privilege to present this information to you today. If I can be of any assistance to you down the road, this is my contact information, and I look forward to seeing you on the Seattle Study Club Trail someplace. Thank you very much.